Okay. Good evening, respected teachers, my dear colleagues. And today, before we begin our today's academic session, I would like to take a brief moment to wish everyone a happy Valentine's Day. Today is the day that celebrates care, commitment, and connection. And in many ways, that spirit reflects what we do in our cardiac critical care. Our dedication to our patients, our trust in our teamwork, and our responsibility towards itself. Welcome to ECMO Essential, a Heartline mini series under IACTA West Bengal. Today, our topic is ECMO Transport. That reminds us that the ECMO management does not end at circulation or stabilization. It extends beyond the ICU walls into the corridors, ambulances, aircraft, wherever the patients needs us. And we say because ECMO doesn't stop at ICU door, transporting a patient on ECMO is mobile critical care. It demands planning, precision, communication, and calm leadership. We are truly privileged to have with us today Dr. Dipanjan Chatterjee, whose expertise in ECMO management and transport logistics and the whole ECMO society will guide us through this crucial subject. Let us begin our openness, reflection, and active participation through this very important topic today. So thank you very much once again. And sir, please start. The class is yours.
Let me share my slides. Am I audible? Yeah, I'm audible, clear. Many a times we get patients uh, uh, who are away from our own centers. So it is not possible that all ICUs will be having ECMO support. All cities or smaller cities also don't have ECMO support. So they need to be brought to a larger center where ECMO is available. But many a times, this bringing the patient is a difficult task because they will be either on high inotropic support with a low cardiac output, or they are very, very hypoxic on high PEEP. Transporting them with these problems is really a challenging task, and sometimes many may succumb on the way itself. That is why it is easier if the transport team goes to that place, puts the patient on ECMO support, and brings back the patient to the ECMO center. I have no conflict of interest and no disclosures. See, the first case of ECMO transport was done way back in 1977. This was by Robert Bartlett, the father of ECMO. At that point, a 17-year-old female with a pulmonary hemorrhage with good pastoral children was at Burke City. So Dr. Bartlett used to work in Michigan. He was called in. ECMO was just coming up at that point of time. And he went there, put the patient on a VA ECMO support with a jugulo-axillary cannulation. Okay. And the patient was then transported back to the Orange County Medical Center on a US Air Force C-130 transport aircraft. And by road, when they were going from the airport to the hospital, big truck type ambulances were used. You can just imagine 1977, What kind of ECMO machines were there? They're large, huge size, everything uh, occupying space. So transporting that patient was not very easy. The patient was there for 4 days on ECMO and survived and went home. So that initiated the transport saga for ECMO. Why we need to transport the patients on ECMO? As I said earlier, the hidden mortality rate associated with ECMO, it has been found that when we are sending the patients from one center to another without the ECMO support, there is 11% mortality for the infants who are referred from the ECMO center to an ECMO center, but they just died before they received any ECMO, before they even reached that hospital. So that is a significant amount. So we need to have a safe transport of these very critically ill patients for our for their survival. And that safety can only be achieved if we can take care of their oxygenation, if we can take care of their perfusion. So supporting with an ECMO and that then transport increases the safety. It has also been seen that centers with a higher number of ECMOs, they have a better survival rate. That is because the team is much better. They have developed the protocols in place, and many of these patients, even in the Caesar trial, it was shown that if the patient is shifted to an ECMO center, they may not need an ECMO, but they survive because of the better critical care. That is why it came to the hub and spoke model. That is one center, one large center, which is catering to quite a few other centers which do not have an ECMO. So any center having a patient who needs an ECMO to the larger center, and these patients are then shifted. So ECMO transport basically can be divided into two parts. Either the basic thing that we all do is the intra-facility, that is within the hospital. Suppose the patient needs to go to the CT room, or the patient needs to go to the, then we transport the patient within the hospital. It can also be inter-hospital, that is from one center to another for a better care. So in hospital transport, we need most of the things we have to carry. We need to carry the ECMO machine. We have to have a portable uh, monitor, a defib, a ventilator, oxygen, enough. Do not forget about carrying the clamps because they are very important during the transport. And also syringe pumps with battery backup. So all these things are obviously needed, and then we can shift the patient either to OT or radiology suite, or for any other purpose we can shift. We have even shifted the patient or transported the patient outside the ICU to a space where they can see the sun, so that since they have been on ECMO for many days, they they are in a closed space. It's better sometimes for their psychological benefit that they go out and see the sun. That can be done even on ECMO. So when we are taking this patient to CT room, always remember that the length of the tubing needs to be large enough, because the patient is going to go inside and out of the gantry. And so always we check the length of the tubing, whether it is sufficient or not, before we subject the patient to the CT. Even bed to bed transfer, that is also a shifting. For pediatric patients, you have to be more careful. Why? because the length of the cannula inside the patient is very small. So if there is even a small tug on the cannula, it can come out and then you are gone. It's a very big problem if the cannula comes out. So always when we are shifting the patient, especially a pediatric patient, we are very careful about the cannulas. Coming to the inter-hospital transport. Inter-hospital transport has been classified into three types. What are the three types? Primary, secondary, and tertiary. Primary transport is we have an ECMO center from where the ECMO team goes to the referring center, where the team initiates ECMO, stabilizes the patient, and then the patient is brought back to the ECMO center. This is primary transport, which is the commonest form of transport now. What is secondary transport? Suppose the ECMO center sends the mobile ECMO team to the referring center. There, the patient is already on ECMO. Suppose we are going to another center where, because the patient was getting delayed, the patient already was put on ECMO, and then we assess the stability or do everything before we shift the patient back to our ECMO center. Understood? And third is the tertiary ECMO transport, where suppose the ECMO center is full, which was happening during the COVID days. The capacity is full, but a patient will be needing an ECMO. So the ECMO team goes to the referring center, initiates ECMO there, stabilizes the patient, and then shifts the patient to another ECMO center. That is tertiary ECMO transport. So primary is the commonest one. Secondary sometimes is done because suppose very common for the patients who are going for a transplant. Suppose the patient is on ECMO for a long time, but the patient is not recovering, needs to be transported to a transplant center. Then the team from the transplant center, they come, assess the patient because he or she has been on ECMO for some time. The patient may not be all okay. So everything is assessed, then shifted back. And the tertiary is where ECMO team goes, initiates ECMO and shifts to another center. So before we transport, the pre-transport referral and the transport of the ECMO team period, that is the time of before the patient is put on ECMO, that is of the prime importance. Because that is a time which is the longest time the patient is not on ECMO, is not under control, and the patient is deteriorating. So we try to minimize that time. Once there is a referral, we try to expedite as soon as possible. The ECMO team needs to reach the patient. Once the ECMO team reaches the patient, that is the ground time. That is when the ECMO team assesses the patient, takes the consent and initiates ECMO and then stabilizes the patient. And finally, the patient is shifted back to the ECMO center, where transporting back to the ECMO center is a priority and where the safety of the patient is a priority. We don't hurry at that point of time. So always the most crucial time that we can save is by reaching the patient as early as possible. But there are a lot of glitches that come over. Either the relatives are not very agreeable, or we do not get an aircraft on time, or if we are going to a distant place, we need to take a car or something, whatever it is, we do not get those conveyance on time. All those things are very important. And depending on the mode of transport, it can be either by the road transport, usually maximum approximately 400 kilometers we can carry a patient by road. Or it can be an air transport. Air transport is again two types, either a helicopter transport or a fixed wing aircraft. And finally, the hybrid transport. What is hybrid? It's obviously the ambulance will take the patient to the airport, and from there, either by a helicopter or an aircraft, the patient will come to the another city and then go back to the center through a road ambulance. So by both road and air ambulance combination. Sometimes, if especially in the army, they have large transport vehicles, large transport aircrafts, where the whole setup, including the ambulance, can go inside. The road ambulance will go in, and then we can take the patient to another center. That is easier because then we do not have to uh, move the patient much. So when there is a patient who is sick, who is hypoxic or having a low cardiac output, not improving with the conventional modes, the referring hospital doctor will tell the relative first that this patient is not doing well and needs to be transported to an ECMO center. So then he will call the ECMO center, and the ECMO center, the doctor who is in charge, the lead ECMO team, he will talk to the ECMO, his team members, that this such and such call has come and we need to rescue this patient. Then the doctor from the ECMO center will talk to the relative that this is the call that we have got, and we, if you agree, then we can transport this patient, go and put the patient on ECMO and transport. In the meantime, the doctor will also involve the hospital administration. Why? Because many of the logistics have to be taken care of by the hospital administration. Hospital administration will talk to the relatives, talk about the finances, talk about the logistics, and then prepare the logistics, either an air ambulance or a road ambulance, and then we can go for the transport. But in the meanwhile, all these things are taking place. The referring hospital needs to prepare a few things. What are they? Usually, we ask for 1 or 2 units of blood. We ask for an echo machine to assess the cardiac function as well as the vessels. And also, some of the equipments may be available in centers. And once everything is done, the hospital administration gives a green signal to the ECMO team. ECMO team then can go to the transport, further transport, going out to the referring hospital. Mobile ECMO team, what is the composition? Usually it is dependent on the center or the patient requirement. Mostly it's an ECMO intensivist who usually does the cannulations. But sometimes we also take along with us cardiac surgeons. If it's a VA ECMO and we are not being able to cannulate, then the cardiac surgeon is very, very important there for the cannulation part. We also have to have a perfusionist in the team to take care of our ECMO machine and circuit, a nurse who is trained in ECMO, a physician assistant to assist us in our cannulations, a technician, and also the transport staff. The technician will arrange for all the drugs, will arrange for the uh, things like syringe pumps, etc. Are there or not? Everything has the technician takes care along with the nurse. How do we plan? I mean, before we start the ECMO transport program, we need to plan early. Maybe 3 months before you start the transport program, you have to plan about the equipments. What are the equipments that may be needed for the transport? Nowadays, there are various smaller equipments which are available, like the smaller uh, ECMO machines, which are portable enough and can be carried by hand. They are lightweight also. Also, we need to modify our trolleys sometimes so that all the equipment fits into the trolleys. Some centers, mainly in the US, they have large ECMO air road ambulances where the patient can be put into the ambulance and also done the cannulation there itself. So, but we do not have those facilities in India. Many a times it is the routine ambulance that we are using for the transport of other patients. We take that same vehicle for ECMO transport. Secondly, you need to train the personnel. These people need to know that they are going to a different place to put the patient on ECMO and transport back to the ECMO center. And they need to be prepared for any eventuality because they are not going to get any help outside. So, by simulation programs, by various other means, you train those personnel to take the put the patient on ECMO and then transport. Third is very important, admin and logistics. The admin needs to be on your side. Otherwise, you will not be able to do any kind of transport because many of the logistics have to be arranged by the admin and they have to be ready 24 into 7. A call can come at 2 o'clock in the midnight, and then if you are not getting anyone to talk to the relatives from the admin side, then it is very difficult to put the patient on ECMO and transport. So, admin has to be sensitized about the urgency of the situation. And if you have everything in place, you are prepared to face the adverse challenges. So, transporting by road, we have a checklist of equipments and drugs which are needed for transporting the patients. And all those things are we carry along with us. Even gauze pieces, syringes of various kinds, drape sheets, connectors, our sterile ECMO clamps, seals, gloves, etc. Everything. Don't need anything from the other center. Also, the patient may not be in with proper lines. There, we need to take our central arterial lines, gates, etc., and also the arterial. If the patient has a arterial line, that may not be compatible with our own transport monitor. So the transducer and a cable needs to be taken along with us where we need to change the transducer where the patient was before. Do not forget heparin. If you forget, then you will not be able to put the patient on ECMO. As well as sometimes we carry the ACT machines. Do not forget about the puncture needles, about the guide wires of various sizes and lengths of the serial dilators. All these things are essential. Carry various sizes of cannula with you, not a single piece, a multiple piece that need to be carried along with your equipment. Suppose you are facing a problem challenge in cannulation in with one size, then you can go down to a lower size and then you can carry it. So all these things are important that you have multiple sizes of cannula and equipments. Carry the hemotherm, normal saline bottles, and ECMO circuit. Sometimes we say that we carry two ECMO circuits along with us, but because if one of the ECMO circuits gets blocked or the oxygenator, there is a clot formation during the transport. Somehow we have missed out on the heparin, or if the heparin is not been very adequate, then sometimes you may have to change the oxygenator even during the transport. So we always take an extra oxygenator along with us. And these are the ECMO transport stands. I would like you to see that these transport stand we are custom made. They can be kept at the side of between the legs so that you will see that machine can be kept in the center of these stands and all the equipments can be hung from these hooks. Portable oxygenator cylinders, the hard scissors, ECMO line holders, all these need to be carried. If you are carrying a Centrimag machine, do not forget about the Centrimag flow probe and a backup console. When you are carrying a Mackay circuit, Always remember the hand crank has to be there with you, because on the way, if the patient is having a power failure kind of situation, the pump failure kind of situation, and then you have to do a hand cranking, you need to be better prepared for that. And all the drugs, what is the drug that you need, what concentration, everything needs to be prepared. And this is what we carry, a cart which has almost many things. And you can also see the water bottles. When a 1 liter water bottle, why it is there? Because we are going away to a longer distance. The personnel may be thirsty, and we need to have our but they should not be feeling that during the transport they have become tired. So we need to keep them freshened, awake, alert, so that they can transport well. And this guitar bag is nothing but it carries the cannulas of various sizes. So when we transport by road, we usually take two ambulances. Why two ambulances? Why it is important? Because suppose on the road, any mechanical fault happens in one of the ambulances where you are carrying the patient, you can definitely shift the patient to the another ambulance and then carry on with your journey. Secondly, there are so many equipments that we have to take that once the patient is within the ambulance, there is not much space to carry those equipments. That we need to do by keeping those equipments in the other ambulance. Very important point is that how much oxygen do we need to carry? We need to carry the double the requirement that we know. We need oxygen both for the oxygenator, that is the ECMO circuit, as well as for the ventilation. We need to calculate how much oxygen per hour is needed and multiply it by the distance and the time you need. If you need, suppose 500 liters of oxygen, you carry 1000, because you may have to stop in the between. You may have a mechanical fault in between. Somewhere, if you are delayed, the patient should not die because of the lack of oxygen. And reach the patient at the earliest, as soon as possible. Once you have reached, the second phase starts. That is, you go and assess the patient. What are lines are there? What is the cardiac function of the patient? If there are no lines, you need to put in a lines there before you start off with the cannulation. Then you talk to the relatives about the consenting process. Why this is important? Because consenting you are doing at a different place. You need to have a written consent for all the problems that may happen. And once it is done, you go for cannulation, and the most experienced person in the team usually does the cannulation. Because in that place, if there is no point of experimentation, there is no point of teaching. It is, we have to do it at the earliest, at the best way possible. You cannot have a hematoma, you cannot have a cannulation which goes wrong. Then your transport will become very, very difficult. Once the patient is cannulated and put on ECMO, you ascertain the cannula position, check how much is the maximum flows that can be attainable, and optimize the ventilation and the medications of the patients. Then stabilize the patient initially. See that there is no hematoma or bleeding from the cannulation sites. And then you call the transport team to take the patient from the hospital to the ambulance. So this carrying the patient on a stretcher to the ambulance is a difficult task. You can see how many equipments are there kept at the leg end of the patient. So much like it is a myriad of lines, and all these equipments may be sometimes overwhelming. Secondly, the lines may get kinked under the legs or under some of the equipments, and the flow can come down. So kinking has to be avoided, and you need to see the face of the oxygenator and the our ECMO machine monitor. How much flow is there? What is the color of flow? All the things need to be visible. And sometimes, if the patient is in a hospital where lifts are not functioning, be prepared to carry the patient like this to the ambulance. Once it is done, you shift the patient to the ambulance. You can very well understand that any point of time, if the wires are hanging around, if the lines are hanging around, they may get caught up in the edge of the bed, in the edge of the doors of the ambulance, and may get pulled off. So be very careful that all the lines and our three ways, etc., everything is over the patient, not hanging around. So before commencing on the journey by road, ensure that the patient is hemodynamically stable. Emergency drugs get loaded, and double of the expected need of oxygen is there with you. And sometimes we need blood products if the patient is having a bleeding, or most of the times we carry it along with us during a long transport. Secure the patient, secure equipment, and ensure that no equipment is left behind. Then you have to again go back to that hospital and get those equipments. During transport, you have to monitor just like an ICU with ECG, saturations, invasive blood pressure, EpCO2, urine, everything. And do not forget, what is the flow? What is the color of the tubing? Whether there is a difference in color of the tubings or not. When you come back to your hospital, you need to shift the patient from the stretcher to the bed. You can very well understand that this has to be very, very coordinated effort. Every equipment, every line moving in sync with each other. If that is not so, then the lines may come out. So during the road transport, there is a movement relative to the surrounding and movement along with the surrounding. Okay. So what happens? Referring hospital, patient is on road transport, reaches the center, ECMO center, via various steps. So referring hospital to the ambulance stretcher, and this movement is not with the hospital bed or the stretcher, but within the ambulance, the entry and exit of the patient has to be very carefully monitored. So that the lines do not come off. Air ambulance transfer is similar, but a little bit more complicated in the sense that we have to carry the same things for transport that we do for the road transport, but in a much more compact fashion. We don't have too many people to support us. We don't have too many equipments. If one fails, we carry another. That will not be there. So we need to be compact. You need to be very efficient. Only 3 or 4 people will be going along for a transport. Here, the referring hospital, patient is shifted to the from the hospital bed to the ambulance stretcher, then goes to the nearest airport, from where the patient is put on the aircraft, goes to the destination airport, and again back to a road ambulance, and then goes to the ECMO center. So many entry and exits are there that you have to be very, very careful about your lines and equipments. What happens within the flight? There are certain changes that happens within the flight, like even if it is a pressurized aircraft, the atmospheric pressure is low. So the partial pressure of oxygen in blood goes down. So that we have a sometimes the saturation drops. Secondly, since the atmospheric pressure is low, airfield cavities can enlarge. So always before shifting a patient for air ambulance, we do a chest X-ray. Rule out the any pneumothorax that is available. So you have to put a chest drain and then only then we transport if the patient has a pneumo, because the pneumo can increase during the air transport. Secondly, as I said, the partial pressure of oxygen goes down. We need to go up on the floors for that. Temperature is low, the patient may become hypothermic. The aircrafts may not have adequate supply of your power. So you need to carry your battery pack sometimes, extra battery power packs with the ECMO machine. And there is a lot of noise within the aircrafts, especially the helicopters. And you may miss out the alarms at that point of time. And because of the vibration, acceleration, deceleration that occurs during landing and uh, taking off, the equipment may fall down. So all those things they have to be taken care of. There is very, very cramped space. Everything kept together. You don't have much space to move. Secondly, the light within the aircrafts may be less. So you may not be able to see adequately what's going on, if the color of the tubings are changing or not, if the oxygen getting disconnected or not. All those things have to be very carefully monitored. And membrane oxygenator and pump position. So always we keep the membrane oxygenator and the pump position on the at the level of the patient. Okay. Or below the patient. Transporting the COVID patient was difficult, but once we had those pods to carry these patients, it was easier. Before you embark on an air transport, you have to know what is the type of the aircraft. What is the ingress and egress? You just imagine taking a patient up through these ladders along with the ECMO machine, how it will be. And this aircraft has a wide door, easy to ingress and egress. Secondly, power connections with. So these are practical scenario that you can see. So post transport, once you have got the patient back, you need to hand over to the receiving team, and the relatives are given a briefing about what happened during the transport and how well the patient is during the transport. Equipments need to be cleaned and restocked. Whatever equipment you have used, whatever drugs you have used from the cart has to be restocked. You sit down, all the team members who have done the transport, debrief amongst yourself what went right, what went wrong, and review any critical incidents that has taken place. So there is always a room for improvement. Disasters like kinking can always occur. Discharging of the ECMO console, the power failure can occur. You have to go for a hand crank. So once we had a patient who from Dhanbad to Kolkata, 300 kilometers, 50 kilometers down the road, there was a power failure and we had to start hand cranking. It is difficult to transport a patient for 300 kilometers if we have to hand crank. It's not safe. But Fortunately, we have had another console, another circuit, and we primed the circuit, connected to the patient, and then we could run the ECMO. So always be prepared and take quick decisions during the transport. Do not have to think twice. Be prepared for that. And also always train the transport staff. The ambulance staff needs to be trained because they are your saviors outside the hospital. So what are the complications that can occur? Adverse events. This was a pre-COVID era. It can be patient-related, equipment-related. Problems can occur because of the transport vehicle breaking down, or it can be human errors or environment-related problems. Suppose the patient, you are going in a air ambulance, and when you are reaching your destination, there is a huge cyclone there, cannot land. You have to go to another city. All these things are possible and have happened. And the complication severity can be categorized into category 1, where there is a very high risk of mortality, morbidity, unless we respond within seconds, like air in the circuit, battery backup failure, clot in the circuit, cannula getting dislodged, pump stops. All these things need to be addressed immediately. Second category is high risk of morbidity, mortality, but we have response time within minutes. Like the patient is accidentally extubating, patient has acidosis or arrhythmias, all these things can be taken care of. The oxygen supply getting disconnected, and then you see the saturation coming down, you can reconnect the oxygen supply. If you are on a VA ECMO, cardiac arrest happens, do not worry. You can just have to defibrillate the patient and carry forward. Circulatory instability can be there. All these things, because we need to carry our inotropic support, vasopressors, we can start off within the ambulance itself. Category 3, where there is no risk of morbidity and mortality but needs attention, like technical problems within the ambulance or the aircraft, or there is an accident of the ambulance, bad weather causing a delay, or recirculation happening, or hyponatremia, hypoglycemia, all those things. And finally, the low risk, but they need to be noted. Like you are ready for transport, but the aircraft hasn't arrived. So airport delay. Patient is having an anemia, need to give a blood. So you can go to the ECMO center and then start transfusion. Sometimes there is a change in destination. So you are on the way, the patient deteriorates, and you have to immediately go in one center, another place, another hospital, stabilize the patient, and then go. Or the air ambulance has to detour to another location, and then you have to stay there for a night in another hospital. All those things are very, very important, but they are not that risky. How safe is ECMO transport? So this again a 2021 article that shows that the pre-COVID data of the 2,647 transfers, primary transfer was 90%, ground transport was 91%, and only 4 deaths were related to transportations. The adverse event is so low. Mortality rate is 0.15% only. So if you want to read further, this is the article that you go to. ELSO has published the guideline for transport and retrieval of adult and pediatric patients with ECMO transport. It's freely available, and please read it. So transportation by an ECMO team is difficult, challenging, but with an experienced team, it is safe. Second, the proper planning and preparation has to be there before you start your ECMO transport. Remember, you are initiating ECMO in a remote location. You have to be prepared with everything, every eventuality. And since you are in an out of hospital environment during the transport, you do not get the support of the hospital during the transport. So various unusual situations have arrived in our cases for during transport, and we had to take corrective actions immediately. Finally, it's teamwork which leads to a safe patient, say, and with the help of experienced staff, the patient is safe. Wish you all a happy transport journey. Thank you.
Thank you very much, sir. Any question? There are two questions in chat box. What is the act of levels? What is the act levels via ECMO? The second one is what is the way to calculate the recirculation fraction if PA is not placed?
Recirculation is, see the color change in the two limbs of the drainage and return. If the drainage becomes bright, then there are two things only. One is the recirculation is occurring, or the patient has a very low cardiac output. That can be the cause of the same color, the same bright color. So we usually rely on the color differences between the drainage and the return limbs to check about the our uh, recirculation. But also before the transport, we are doing an X-ray. We are seeing how much distant the cannula tips are from each other. So if they are close together, we need to pull them apart. What was the first question?
Dr. Prem has have these questions. What's the ACT levels via in VA ECMO?
What are the ACT levels?
ACTO.
ACT levels for VA ECMO is always a little bit on the higher side. We keep it initially during the transport, we keep it between around 180 to 200 almost, especially for pediatrics. But during the stay within the ECMO center, we can come down to around 160 to 180. But more importantly than ACT is the APTT, because over the long run, ACT is mainly for situations where you have a higher heparin load in the body, in the serum. When the heparin load in the serum is less, then ACT is not a very good indicator of your anticoagulation. Then we have to depend on your APTT levels. Or if you have a anti-10A, then that can also give a guide. We don't use anti-10A, that is not available with us. We use APTT and we keep it at least twice that of the normal. Troubleshooting in category 1. Category 1 is mainly where we need to do immediate support, because in category 1, like air in the circuit, it's same. Troubleshooting is same like you are doing during the your patient within the your ECMO center. We will have I think troubleshooting. Was there any session on the troubleshooting during these few sessions that we have had, Mona Lisa?
Sir, we actually had this class, the troubleshootings. It
Okay,
has
then
been
that
done.
must have been covered by Hirak and Arpan. If you need a troubleshooting scenario, we can again have this session later on. But
Definitely, definitely, sir.
specifically four situations, four things that you need to know about troubleshooting is air in circuit, the pump failure or electrical failure or oxidator change. All these things need to be done. And also if the patient is having in hypoxia on VVA, all these troubleshootings we need to know before we embark on our ECMO journey. Why VA ECMO ACT is higher than compared to the VV ECMO? Specifically because in VV ECMO, a small clot will lodge if it is there, particulate matter. It doesn't go to the brain, it goes to the lungs. Whereas in VA ECMO, it straight away goes to the, it can go to the brain and cause CVA. So we do not want any kind of clotting in these VA ECMO patients. In VV ECMO, we have run ECMOs with high flows without any heparin many a times. But VA ECMO, we do not venture into that.
Any other question? Okay, thank you, sir, for an exceptional and practical session. Today, we learned that the ECMO transport is not just shifting of the patients, it is the transporting the physiology, the technology, and the responsibility together. So, the preparation, protocol, and teamwork makes the difference between the risk and the safety. So, let us go back and strengthen our systems, our checklists, our coordination, and our readiness. Because it is true that ECMO doesn't stop at ICU door. Thank you, everyone, for attending this class and for your um, time and cooperation with all of us. Thank you very much, sir, for the excellent presentation. And for the next class, we will have another very good topic, and we expect all of you again with us. Thank you very much.